All right, it is 12 o'clock, so I am going to go ahead and get started. I can't actually see the participant list um, right now because of the PowerPoint. So, I have ground rules to get started. Please mute, or you've been muted. So if you would like to speak, go ahead and unmute yourself. My name is Rose Locklear, and I will be doing the first portion of this webinar. I do want to let you know that it is being recorded. Um, and if you are sharing your video, please turn that function off. We're trying not to slow down the system. Everybody is experiencing probably higher network volumes than usual. You know that I am. So if there's any interruption on my end or otherwise, please be patient as we're all experiencing a different environment these days. So without further ado, I'm going to go ahead and get started. If you do have a question as we're going along, please type it into the chat box. Sarah Anderson, the Field Services Director, is going to be moderating the questions. And so as questions come in, if it's relevant to the document or what I'm talking about in that moment, then by all means we'll answer that question. If it's specific to a scenario, then we're going to hold those kinds of questions off for our discussion at the end. There'll be plenty of time for you all to get your questions out there, and I will encourage folks to interact and participate and share experiences with one another. That's really the intention here. So again, my name is Rose Locklear. I'm Field Services Program Manager with Rondi Ann, whom you all, I do believe, are familiar with. And I have joining me today, Tammy Norville from the National Organization of State Offices of Rural Health. She's located all the way over in North Carolina. And Tammy is really our billing and coding expert. So she's going to provide that level of expertise and knowledge. And my background is really with regard to health policy. I've been a telehealth coordinator for the Oregon Office of Rural Health when I was first hired, and have kept my finger on the pulse of what's going on in the world of telehealth for the past few years. And as anybody will tell you right now, this is really an unprecedented time as far as the policy that's coming out in rapid fire with regard to telehealth. So I'm going to start this session by really going through what's going on at the federal and the state level and share a policy resource that I have created with you all. So rather than creating a whole bunch of slides that will essentially become dated within, most likely by the end of the week, I have created more of a plastic resource that allows for a lot more freedom and flexibility for modifications and updates. So I'm going to walk through that with you all and show you exactly where to locate resources with regards to policy, billing, and all those sorts of things. So back to the agenda for today, I'm going to go through the first part with regards to federal and state policy resources. Tammy's going to jump in and talk a little bit about how what the implications for the CARES Act are for you all at rural health clinics with regard to telehealth. And then a large portion of this is really going to be an open discussion to answer some of the questions that you all have around telehealth, billing, and coding. So I'm going to stop sharing this PowerPoint and actually get into this resource. You all were sent a link to this earlier today in your invite. So if you have the capability to navigate through that resource while we're on this, while I'm going through it, it may be especially helpful to you. Otherwise, you can just follow with me. Again, I see a lot of videos up, so if you have just joined us, please disable your video so that we're not bogging down the system. And now that I've got a bunch of windows in here. Okay, is everybody able to see the resource? You should see COVID-19 telehealth resources for Oregon clinics and hospitals.
It is showing up, Rose.
Fantastic. Thank you, Sarah. I feel like we're on a spaceship or something here. Okay, so I want to first start off by talking about really the importance of definitions when it comes to reimbursement. So telehealth and telemedicine have really been in our common everyday vernacular, really these catch-all terms when it comes to anything related to video or two-way communication that is done in any sort of virtual platform. With regard, so with regard to payer source, we need to be especially conscientious when we're talking about telehealth, telemedicine. So for the purposes of Oregon, so that's going to be private payers and Medicaid, Oregon has a much more loose definition and really lumps telemedicine and telehealth together and describes the use as being interchangeably and can include two-way video and audio communication, phone calls, whether billed using ordinary codes or specific telephone codes, and services such as secure messaging provided through online tools and portals. So again, that's Oregon and specific to Medicaid. When we get into Medicare, Medicare is much more specific with their definition. Medicare's definition for telehealth is services, including office visits, psychotherapy, consultations, and other medical or health services that are provided by an eligible provider who isn't at your location using an interactive two-way telecommunications system. So that's going to be that audio and video component, and that is what telehealth means to Medicare. So anything that is not two-way audio video for the sake of Medicare is not considered telehealth. And so that's when you get into those virtual visits, the e-visits. I just want to show you this little graphic and I'll show you guys where to locate this. This is extremely helpful when you're trying to figure out what is this visit that we just had here. So I really love the visuals here. Are there video or pictures? If the answer is yes, is it in real time? If the answer is yes, then that is, again, for the sake of Medicare, that is considered telehealth, and then that's going to take you down the health coding route. We'll get more to that as we progress through this. For the sake of this document right now, I just kind of want to disentangle the differences between telehealth and then virtual check-ins and e-visits, because again, you'll want to make sure that all of those are coded appropriately. So then, if there are not video or pictures, then you kind of flow through this to figure out exactly what kind of visit it is for the sake of Medicare. Again, Oregon, a little bit more loose on the terminology, and we'll get deeper into Oregon stuff as I navigate through this with you guys. Again, originating and distant site, I'm sure that you all have become pretty familiar with that terminology at this point. So prior to COVID-19, RHCs, as you are all aware of, could not be the distant site. For the sake of Medicare in Oregon, and Medicaid in Oregon and private, this is opened up, and even Medicare has set the groundwork for RHCs to become the distance site without getting you the guidance. So we'll get into the guidance piece here a little later. For both Medicare and Medicaid, there were stricter guidelines prior to COVID-19 about originating sites. A lot of that is opened up as well. For both Medicare, Medicaid, and private insurers, there was a lot of requirements about platforms being HIPAA secure, and across the board that has opened up for this time period. And so they're allowing for platforms like FaceTime and Zoom and several other things. I have a HIPAA document if you want to get down into the nitty gritty, but essentially all that are not public facing. So back to this guy here. This is really where I'm housing everything that's coming down the pipeline with regard to telehealth here in the state and on a federal level. And if you open this up at home and you're having any issues with what's populating here in the right, I would suggest checking to see what browser you're using. Internet Explorer doesn't seem to be interfacing really well with this platform, so I would encourage you to use Chrome or Firefox. If you click on any of the blue text, it's going to take you to, for example, just do this one, it's going to take you to whatever is being discussed. So in this particular example, referring back to the statute where telemedicine and telehealth are defined for the state of Oregon, as well as distance site and originating site. And each, like I said earlier, each payer really defines telehealth and telemedicine. I hope to got into some of the nuances there with Medicaid and Medicare. I also have created a document. This is telehealth reimbursement overview, and this describes Medicare, Medicaid, and private insurers guidelines and rules, but this was prior to COVID-19. Nonetheless, I'm still pulling up this document all the time because a lot of new rules and regulations are referring back to the way things were, or it's just nice to see where we were a month and a half ago versus where we are now. You can look through this in these two sections about the CARES Act and Oregon's Medicaid waiver in your own time, but I really just pulled out each section for the CARES Act and each section that was relevant to telehealth and outline that, because the idea here is really to tell the whole picture of telehealth the federal level, the state level, and then how all the different temporary administrative orders and payment resources tie back to those bigger pieces of legislation. If you have not seen the 1135 waiver, I highly doubt that, but if not, it's right here to our right. And again, the pieces that are specific to you all, allowing the rural health clinic providers to bill their prospective payment rate and other permissible reimbursement when providing services from their your alternative physical setting. All those specific pieces are outlined here in the Medicaid waiver, easily accessible. And again, if you want to get back to the original document, it's hyperlinked right there in the top. So I think that you all have a lot of questions with regard to payment. So I'm going to spend the most of my time showing you all where and how to access payment resources. So before we get to that, though, I do want to draw your attention to Oregon's temporary administrative orders. These have been coming out like rapid fire since midway through and even before May. And I found myself getting lost in the amount of them and what exactly they were saying when you're just pulling up a hyperlinked list. And so the intention here was to pull out all the temporary administrative orders that are specific to telehealth, and they're ranged here from the most recent one published on the 26th that outlines payment parity. And I wanted to front and center pull out the need for the rule, why it was enacted, and then a temporary description. So if you all are trying to find this administrative order, and I do suggest looking through them if it is relevant to you, because they have every single temporary administrative order is going to have all the nuanced language. And then if they have a reference document, like the rules that were updated, the OARs that were updated, or any links back to the HRC guidelines, those are going to be specifically outlined in each of those administrative orders. So again, you can simply click on the link. It's going to take you to the entire administrative order. But if you're really just trying to quickly get a glance through here and figure out which one you need to find, you can see all that information over here to the right. I imagine that there are definitely some specific ones in there for you all as RHCs. Some ones about prioritized lists, and then specific like information getting down into telemedicine rules that changed under the current emergency. So payment, let's get down to business here. Again, as I mentioned, the Oregon Health Authority is describing telehealth services as synchronous services, both audio and video capabilities, when billed with the same codes that would be billed for in-person services, and when mode of delivery is indicated by the use of specific modifiers or place of service codes specified by the plan. OHP created a really helpful billing document at the beginning of all of this. So again, there's documents are all described over here to the right. I started off organizing the Oregon Health Plan, Health Authority documents, and then followed by Medicare documents. So when all of this, oh no, 320, Oregon Health Plan came out with this document, this is a really, really helpful one if you're trying to disentangle telephone, telemedicine, telehealth services. Again, for the purposes of OHA, telephone, telemedicine, all kind of lumped together and called telehealth. So what they describe here are really the expanded coverage described in the HRC guidelines, and I link back. You can click right here on the guidelines and pull them up. This A5 note is going to be super helpful to you guys. It's going to download over here because it's a Word document. And then this is going to go through all specific codes. So a lot of these documents that are linked over here, because they're in the payment section, they're getting down into the specifics of how to code for these services. So this is going to, this whole document here covers fee-for-service Medicaid, opened up new services under FFS Medicaid, outlines the requirements for CCOs to cover telehealth in the HRC guidelines, and it also gets back to that A5 guidelines. If you all partook in OHA's webinar yesterday, then you heard that they are revising the A5 list this week. So I will have that in here just as soon as it comes out. Also, description in here describes codes and changes for telemedicine, physical health, and behavioral health. So that's going to be another important piece there. I can't emphasize enough the importance of these documents, the A5 and the HRC guidelines. Let's see here, what else? So if there are dotted lines and you all click on them, the document's going to populate over on this right side here, so you can kind of easily scroll through it. Again, any of these memos that are produced by OHA are going to have a great deal of information for you in there about what you should do and why this is happening, and the relevant documents that you all will need. And back to some of the language around telehealth consultations and all of those nuanced things. So again, all of OHA's payment pieces, how to bill specifically for COVID-19 things outlined in this document. You can click on any of the hyperlinks that populate over on the right side to navigate. Same thing if anybody is doing dentistry, the telehealth guidance in general. So this is produced by OHA and DCBS. And essentially, if you haven't seen this one yet, it's OHA's expectations to the private health plans, requesting that they cover telehealth services by in-network providers in place of in-person visits. It's also getting into some specifics about examining reimbursement rates for telehealth to make sure that they're adequate to meet patient demand, cost sharing. There's essentially across all payers right now, there's really the option to for cost sharing to make co-payments be the same for telehealth as they would be in person, or giving providers the option to remove co-pays altogether. Let's see, post communication on the website. So this is a huge one. If you didn't already know, OHA requested that private insurers post some information on their website about how recipients or beneficiaries are to receive telehealth services, and how you all are to bill a private insurer for telehealth services. So please do check your when you have a patient and you want to bill for telehealth, please, they are private, you're going to want to check out the website of that insurer. This also outlines making sure that there's support, and making sure that private insurers support an adequate telehealth network for their beneficiaries, and to use telehealth to ensure that patients maintain access to behavioral health. So all of those pieces are outlined in this document. They're going to send you to specific, again, back to the A5, the statement of intent 6, and the prioritized list is enormous. The A5 kind of pulls out some specifics. And again, that's going to be updated this week. So that is the private insurer. Everything that you could possibly need around OHA is linked here on the side, with, again, regard to payment, and then Medicare. So Tammy's really going to get into Medicare a little bit more, but I just kind of want to touch on Medicare billing guidelines for you all. They have not been released yet, and so what that means is that there's no way to know how much you would receive for a service and what specific codes you would use. There's definitely Medicare telehealth codes out there. Medicare just hasn't come out and said you all can use these codes and get billed for them. So again, Tammy is going to get into the nuances of that. I do find that Medicare, there are definitely a few important documents out there. This one here, physicians and other clinicians. Is everybody able to see that?
Yes, Rose, we can see that.
Fantastic. And so this is the most up-to-date document created by CMS with changes. Again, you're going to want to be super careful about the telehealth section because you just don't know yet if that is exactly the guidance that you all as RHCs are going to be asked to use. However, there is some really good information in here about virtual check-ins and e-visits. Essentially, a big component of the virtual check-ins and e-visits is that it was once limited to established patients, and basically across all payers, established patients for anything related to telehealth, telemedicine is no longer a requirement. So if you see that in Medicare or Medicaid, you can double check that it probably is not a criteria anymore. Opening up to e-visits and virtual check-ins to providers like social workers, psychologists, physical therapists, and occupational therapists. Again, back OHA, there's a temporary administrative order for the Medicaid side of things as well that opens up health to therapists and occupational therapists. Remote patient monitoring, again, a big stipulation there is that was established patients and no longer is just established patients. And there's also some criteria that got opened up there as far as being able to provide remote patient monitoring for acute and chronic conditions in patients now that only have one disease. There's some removal of the frequency and limitations on telehealth. So I encourage you all to get familiar with this document. If these are services that you all provide, there's some important information about end-stage renal disease and supervision requirements. See if there's anything else in here I wanted to draw your attention to. Yeah, I think that those are definitely the most important pieces here with regard to Medicare. Let's see. So that document came out on 3/30, so super relevant. This, the physician document, it's always helpful to kind of in tandem, if you're not familiar with this telehealth services booklet produced by CMS, gets into all of this sort of stuff. But again, you all are really going to want to hold off until you get the go ahead from CMS to say, yes, you can use the MLN booklet and bill just like everybody else. Okay. So physicians, most things that are produced on a national basis, again, are going to be with regard to Medicare. So there's some useful documents out there. The algorithm one that I showed you earlier, as far as how to figure out what kind of a visit it is, it's nested within this a virtual visit algorithm. That is, again, it's right here under the Medicare payment resources document. American, let's see here, American College of Physicians. Pretty sure I have an internet connection. American College of Family Physicians did a nice job pulling out different pieces of different types of telehealth and explaining them and how to bill and code. Again, to be cautious with billing and coding information that is just kind of lumped in there for Medicare in general. So you all can kind of go through these. I again try to simplify your life by providing a description of what these documents are outlining, so that you don't have to pull things up and weed through them. If the document is underlined in a solid, it's going to pull it up in another window. If it is dashed like this, then it's going to populate over on the right side. Finally, resources, web page, startup guides, webinars, and more. So every time there's a webinar, and there's been some really good webinars that have occurred recently, if you all did not see this webinar put on by NARHC last week, I would really encourage you to watch it. This is the one that populates over here on the right side. It's a little over an hour, but it's got a lot of really good information. Definitely, here you can access the slides right here. And I just want to draw your attention to a couple of them that may be especially useful to you all if you were not on this call. So also there's some expansion around home health shortage areas, which you'll want to pay attention to. They again got into the importance of the terminology and outlined the fact that things are moving at such a rapid pace that you really want to pay attention when you're referencing a document. Pay attention to the date, because things that were produced by CMS midway through March are already out of date. Virtual care communications and virtual check-ins. This is a slide that you all probably want to pay close attention to. Digital e-visits is another one that they did a really nice job of explaining how to bill for if that's not something that you're not familiar with, and then going through some specific criteria and things like that. So I have gone well over my time, so I'm going to pass the torch over to Tammy and let her get into some of the Medicare stuff for you all.
Cool. Thanks so much, Rose. And first off, hey y'all, hope you're doing well. In case you can't pick up from my drawl, I'm not from Oregon. I'm in North Carolina. And I just want to say to the state office folks here, thanks so much for having me. I appreciate it. And I just want to give you a little bit of perspective. First off, I'm not clinical. I have lots of certification, and I'm a CPCI and have lots of initials and all that kind of stuff. But more importantly, I've been around for about 100 years. So I've seen a couple things. And so I just want to kind of frame things up a little bit. I'll be the first person to tell you I don't know it all. Nobody does. Let's be honest. But even before we knew the term COVID-19, we find ourselves in an ever-changing environment, but working together, we find the answers, right? It's not up to one person. So working together, we figure it out. And I will say there are lots of resources now, and you're probably in information overload. My unsolicited advice to you is to find some really strong resources that you trust, or sources of resources that you trust, like your state office of rural health. These guys know their stuff. They know how to share the important stuff without getting lost in the weeds. So just be careful where you get your information. Take that as you will. Feel free to ask questions. I think you're going to do it in the chat box. And actually, the first thing I'm going to do is in the chat box, I have, if I did that correctly, yes, it looks like I did. This link is actually to the interim rule for everything we're talking about. And it says in really big letters across the top when you go look at it that this is not the version that's going to end up in the Federal Register. And does everybody know what the Federal Register is? It's where anything that's going to go into law gets posted. Folks have an opportunity to comment on it. Comments are collected. It's scrubbed by whatever department or division is responsible for that legislation, and then rules and guidance are posted. Obviously, in our current environment, we're doing that really fast. So if y'all remember, the CARES Act was signed into law on the 27th of March. So that's an important date, right? because that's when the legislative wording actually became law. So the other thing I want to make sure that you kind of keep in the back of your mind when you're reading all of these guidances and rules and all that stuff, interpretations, PHE, public health emergency. That's what we're in right now. We have a national declaration of emergency, and it happens to be a public health emergency, so it's a PHE. You'll see PHE a lot, and sometimes they don't define it. So just kind of keep that in the back of your head. So what is legislation versus guidance versus rules? What's the deal with that, right? So legislation is the law, right? I'm about to age myself. Those of you that are in that were teenagers in the 80s, let's just say, we grew up watching Schoolhouse Rock on Saturday morning, and there was one called I'm Just a Bill. If you've never seen it, Google it. It's awesome, especially if you have little kids. Guidance is actually kind of the interpretation. It's how we do what the law says we're supposed to do. It's also how in our world, it's how the MAC, who pays us, sets up their payment system, right? So it's really important that the guidance says exactly what we're supposed to be doing. So the MAC can set up the payment system to match what we're doing. Does that make sense? Did I lose anybody? Okay, y'all just yell, and I told Sarah if I forget something just to poke me. So why is that important? Well, I'm going to tell you a story. So let's just say Tammy's Rural Health Clinic has started to bill as a distance site telehealth services. In the legislation, I'm allowed to do that. I'm a rural health clinic, but now the legislation, the legislative language added distance site status during the period of the public health emergency. And it took a legislative change because that's where it says our RHCs, rural health clinics, and federally qualified health centers can only operate as originating sites. That was legislative language. So it took legislative language to change it. So unfortunately, in what we've seen thus far, including this interim rule that I just sent you, it's not called out that rural health clinics and federally qualified health centers can be distance sites. What could that mean? Maybe nothing. Maybe it's inferred, maybe the MAC's just going to go with it because we're in a public health crisis. Who knows how that might play out. But maybe, hear me out, if it's not in the guidance and we're billing right along, our claims pay, everybody's happy, remember this is only during the declared state of emergency for distance site. A year from now, I get a request for documentation review. Oh, wait, distance site for rural health clinic was not in the guidance. Now I find myself in a payback situation plus interest. Am I being chicken little? I may very well be, but I will tell you I err on the side of caution. And I do partly because I've been around for 100 years, but partly because this is for a limited period of time, right? So stop the story for just a second. Hold that thought about Chicken Little. I'm going to come back to it in just a second. Let's take a little commercial break for just a second. So I know that you guys are rural health clinics. I would assume some of you are provider-based, meaning you are owned by or affiliated with a hospital of some sort. But we also have some independent rural health clinics, right? So I want to talk to my independent folk for just a second. The CARES Act did some other stuff too, other than just telehealth, even though that's kind of where we focus right this minute. There are two things I want to mention to you. If you don't know about it, if you will reach out to your state office folks, Rhonda Ann, Sarah, Rosalie, whoever's your go-to there, the Payroll Protection Program and the SBA, Small Business Administration, loans, loans and other stuff. If you are an independent and have interest in learning about that stuff, talk to those folks, and I am happy to help do whatever we need to do to get you the help you need. If you are provider based, my assumption, and that could just be Tammy's assumption, is that your hospital folks will be looking at those programs. But just keep in mind, CARES did other stuff other than just what we're talking about today. It's much bigger than that. And if you saw the price tag on it, you already know that in the back of your head. So just wanted to put it out there. If you have interest, talk to the gang here at Oregon State Office, and we'll get you whatever help we need. Now let's go back to the story. So am I being Chicken Little? Maybe so. Well, maybe not. Time will tell. Hopefully, we're out ahead of this enough that we can get the wording that we need. So, what questions does that raise in your mind? Anybody?
If you all have questions, muted you on my end, so you're going to want to still unmute yourself.
So feel free to unmute yourself and just ask a question if you have one. So some of the things to kind of keep in mind about not just yep, thank you, Sarah, for the nudge. Somebody asked a question earlier about if critical access hospitals bill for emergency department services provided via telehealth and telemedicine. And I'm going to read this directly from the Hospital CMS Flexibilities to Fight COVID-19 dated 3/30/2020. This is what it says about telemedicine. CMS is waiving the provisions related to telemedicine for hospitals and cause and it gives the public law number, making it easier for telemedicine services to be furnished to the hospital's patients through an agreement with an offsite hospital. This allows for increased access to necessary care for hospital and PA patients, including access to specialty care. That reads to me like the patient is at the critical access hospital and they're doing telehealth with a hospital in another location. I did not, in preparation for today, go through the interim rule for the critical access hospital telehealth related rules, but I will. So if I can take that question with me, we will get you an answer other than to see if there's something other than this. Critical access hospitals are called out for other relaxing, and I'm using air quotes like y'all can see me, relaxing of rules, not specific to telehealth and telemedicine. So this is actually a really good point. Another example of where, you know, the CARES Act says that every Medicare beneficiary, regardless of where they live, will have access to telehealth. So do we infer from that that RHCs and critical access hospitals can do telehealth as they want? The guidance should give us the guidance we need in order to make those kinds of decisions. But it's not specific. So that's another one that we need to call out. I'll mention another that is not called out. Despite federally qualified health centers being called out in several places, federally qualified health center lookalikes are not referenced at all. So there are definitely some areas where we need to make sure that we kind of close the gap for the safety net. And I'm sorry, I don't remember who asked that question, but I will get an answer and get it back through your folks here at the state office.
Thank you, Tammy.
We'll get that information out to everybody as well. I have another question that's come in as well. So if a provider is located in Oregon, because we're a border state, we border Washington, and they have a patient who they regularly see in their office in Oregon, right? The patient goes from Washington to Oregon to see their provider.
Okay.
Can the provider do a virtual visit with that patient?
There is nothing in the language thus far that prohibits that. And kind of as a secondary, licensure, just physician licensure, provider licensure is not being restricted to their state anymore. And again, this is all during the declaration, the emergency declaration, right?
And with regard to Medicare, so if it's a private insurer,
that's right.
The question, another piece of information that you really need to pull together to fully answer that question is, and if you have multiple patients, there is the potential for an answer to be different for every single payer.
That's right. It very easily could. And the other thing to keep in mind is in North Carolina, in one part of the state, we have a lot of Medicare Advantage plans, whereas in the eastern part of the state, we don't have many. So the other thing to remember is these rules are specific to regular, and I'm using air quotes, here we call it red, white, and blue Medicare, because you know the cards at least used to be red, white, and blue. Regular original Medicare. So this is not Medicare Advantage necessarily. Now, will a Medicare Advantage plan maybe adopt these rules? Maybe. Just like a private insurer might just adopt these rules since it's for a limited period of time. But we don't know that. What else?
I have another question that came up from our last webinar. A question about clinics being able to do retroactive telehealth billing.
Okay, so I have a question back. Define retroactive.
Now, is there anybody out there from a clinic that would like to?
So if it's for an originating, if all your billing is originating, as long as you're within whoever the payer is for, you know, their timely filing, there you go. But if it's distant went into effect when the president signed the CARE Act, which was March 27th. What you don't know, you know, that means you can bill for it. You don't know if you're going to get paid. You don't know how the payment is going to be, what the methodology is to come up with the payment. You're not exactly sure how it's supposed to look on the claim form, but can you bill it? Yep, sure can.
Thank you.
Recommendations on consent. Whoever asked that question, can you talk to me a minute? Tell me the scenario.
Hi, Tammy. This is Rondi Ann. My question is, do you recommend that the provider get a verbal consent? And what would be the process for getting that verbal consent? Do you have recommendations for that?
So in the telehealth information that is available thus far, normal rules, and again, normal is relative, right? Normal rules are that you get a consent and then you do the service, not at the same time. Now you can do it at the same time. If you get verbal consent, I would make it part of the documentation of the visit. And I would also follow that up with, if they're at their house and they're doing it on their phone or whatever, if you have a form, if you have a way to have a form that they could sign with their finger, that would be awesome. If you don't have that kind of technology, you could mail it to them. You could, at some point in the future, or as close to the time of that visit as you can, if they're giving you consent at that time, I would just follow it up with written documentation. Because remember, we work in healthcare. If it's not documented, it didn't happen, right? So just making sure that you document it, and probably on the telehealth visit, you have a nursey person doing something and a provider doing something, and so maybe they double check themselves. You know, maybe the nursey person actually gets the consent, and then the provider says, I understand you consent, just wanted to reconfirm that, and have them yes or no. And so then the provider can document it too. Document, document, document. And when in doubt, document just a little bit more.
Tammy, do you also recommend that they have an acknowledgement with the patient if it's a non-compliant HIPAA communication method?
Yes, I do. And again, Tammy, being the conservative person that I am, yeah, and I will be honest, that probably is overkill based on the way the rule is written. But in my humble and often ignored opinion, you can never be too careful. And remember, we're in new territory, and this is for limited amounts of time. So rules are being relaxed, but you also don't want to get into, I hate to say bad habits, but bad habits during this time. So making sure, so over documenting will help everybody when we kind of revert to normalcy. And again, I'm using air quotes, to normalcy. I think it'll just be an easier transition. And then, you know, beyond a shadow of a doubt, you've got all your I's dotted and T's crossed. And you don't have to worry about it. Are you guys using FaceTime or Skype or something like that that's not HIPAA compliant at the moment? Do you have folks that are in your Medicare population that have access to a smartphone or something that they can actually do telehealth visits?
And you said Zoom was HIPAA compliant, correct?
There is a Zoom that is HIPAA compliant. However, the free version is not.
Okay.
It's a paid version. That's like some of these, and I don't happen to remember off the top of my head if WebEx is one, but a lot of these platforms have free versions or cost-effective versions, and then they have much more expensive versions. And the expensive versions are what's usually HIPAA compliant.
And in the resources section, I've linked to the HIPAA document that outlines which platforms are HIPAA compliant and which ones aren't, and the relaxation language around all of that.
Awesome. Thank you, ma'am.
You bet.
What else,
All right.
y'all? So I would just like to say, folks at the Oregon State Office, you guys rock. I appreciate y'all putting together this time that we could be together today. And if folks have questions, please don't hesitate. Happy to help any way I can. And if folks have specific coding scenarios that they're having trouble with, don't hesitate to reach out. Because the whole thing is, y'all, if you have the question, I guarantee you there are other people that have the very same question. We're all really working through this together. So if something wonky comes up, don't hesitate to reach out, and not just to folks like us, but to anybody. The last thing I want to say is during this time, I've seen lots of consultants that like to say, oh, I can solve all your problems, and I can guarantee you'll get paid. In my experience, and again, I've been around 100 years, nobody knows it all. And unless, Rose and I had this conversation, unless I am the person that actually takes the insurance card from that patient and enters it from the very beginning and then follows that claim all the way through to payment, I can't tell you for sure that it's going to pay. There are too many variables involved. So just again, like with the resources, make sure that if you work, there are some really good consultants, and like lots of different industries, there are some that are not so great. So just make sure that they are reputable and work with your state office or know the folks in your state. You get good references for folks. Just be careful. In times like we're in, there are folks that like to try to take advantage in every walk of life. So just take a step back, take a breath, and we're all in this together and we're here to help. I really appreciate y'all having me, Rose. Thank you so much.
Thank you so much, Tammy. I really appreciate you being on here today. All right, folks, we've got 3 more minutes left. If there are any final burning questions that you want to get off your chest, you're welcome to unmute yourself and ask or type them into the chat box. Otherwise, we're going to wrap this thing up. It is recorded, so it will be available on our website. Again, Oregon Office of Rural Health, if you aren't familiar, we have a COVID-19 page where you can find the resource that I've discussed today. And as I mentioned, it's constantly being updated with all of the new things that are coming out from CMS. As soon as that guidance comes out, which is expected this week, I'll make sure that Ronnie Ann gets it out to you guys. And if you do have any specific questions, or if you're getting rejections, please do reach out to us if you have any questions. We, again, are here. We're here to help. So thanks so much.